We've been discussing congenital heart defects. This is Stephen Holloway. This is Nursing 203, Module A, and we've been looking at congenital heart defects. This is the first in the series of defects with increased pulmonary blood flow. We're going to be discussing atrial septal defects. Atrial septal defects occur in 6 to 10% of all congenital heart defects. Girls tend to have this 2 times more than boys do. What's going on with an ASD, or atrial septal defect, is there's an opening between the left and right atria. Because of that opening, blood is shunting from the left side of the heart, or the left atrium, to the right side. Because if you remember, the pressure is greater in the left atrium than in the right atrium. Because of that pressure gradient, the fluids travel from an area of higher pressure to an area of lower pressure. This is what they call an acyanotic defect. In other words, there's not decreased oxygenated blood moving out into the systemic circulation. Because this is a acyanotic type defect, many times this goes undiagnosed until school age. And what happens is the children in school age basically tend to start having a little bit more problems. They get more active, and the murmur becomes more prominent during that time frame. Unfortunately, many times though, this ASD is associated with other defects and can cause right ventricular hypertrophy because of the overload of fluid that's going into the right atrium. Because the right atrium overloads, the fluid is then pushed down into the right ventricle, causing right ventricular hypertrophy. So you can get hypertrophy of both the right ventricle and the right atrium. It also causes increased pulmonary artery blood flow, because as it goes into the right atrium, you can get a reverse because there's more fluid going into the right ventricle, more fluid is going out into the pulmonary arteries. So you see an increased pulmonary artery blood flow and size on these children. This is just a representation looking at the changes that go on. Again, on the left is the normal flow of blood. Then you look at the right and look at the changes that go on. You can see the oxygenating blood coming from the left atrium, going through the defect inside the wall between the two, and then moving into the right atrium. Then that blood begins to mix in the atrium and mix in the ventricles, and then that blood is then sent back out and back into the lungs to be oxygenated. So you're really just sending oxygenated blood back into the lungs to be oxygenated again. So you're really not sending out any deoxygenated blood out into the systemic circulation. Some of the clinical manifestations, typically these children are asymptomatic. Again, many times it's not picked up into early childhood. Hopefully a good practitioner will pick this up as part of the well children and hearing a murmur on these children. Many times that murmur is very soft, systolic murmur, and again, it can be missed because it is so soft depending on the size of the ASD. If it's a very large ASD, the murmur is going to be louder. If it's a very small one, then you may not hear much of a murmur. The other things you may hear is a very widely split second heart sound. This is very diagnostic, and it's related to an increased blood flow causing the pulmonic valve to close later than the aortic valve. It's not affected by respirations. If you get an echocardiogram on these children, which is one of the major diagnostic tests that we're going to look at, you want to get one with color flow Dopplers, and it may show enlargement of the right side of the heart and the pulmonary circulation. But you can also see that blood flow going across from the left atrium into the right atrium. If you get a chest x-ray, you may or may not see increased heart size. Again, these may not be diagnosed to these children or at school age. Treatment, typically these are not treated unless the child is symptomatic. Most of the time, if a lot of times if you hear it early, they may watch if the child is asymptomatic, because many times these will close on their own. Remember, we talked about the foramen ovale, which is that opening between the ventricle, between the atrium that's there as part of the fetal circulation. So these may continue to close, and what that ASD may be that's not closed off properly. So time may allow these to close. Usually, if they don't close spontaneously by 2 years of age and they're symptomatic, then they will go for surgery. But it's only indicated if the ASD is large and the child has congestive heart failure. But if they're asymptomatic, they're going to wait till they're 2 years old before they do surgery. Preschool age, if it's needed, certain ASDs in non-surgical devices, they can actually go through and put a patch there. Again, they can do suturing or patching from there as they begin to do those type of changes for that. This is, if they have to do surgery, it is an open heart type surgery that has to be done. I apologize, I had to step away for just a moment. We were talking about treatment of atrial septal defects. Typically, treatment is only if the ASD is large and the child has congestive heart failure. Usually, if this child is asymptomatic, we wait and watch. Large majority will actually spontaneously close by the age of 2 years. If they do have signs and symptoms of congestive heart failure, we're going to use some of the diuretics to control it. We may put the child on a little bit of digoxin or something, depending on what's going on with them. But usually the diuretics in these type children will control that. Surgery is needed. Preschool, again, if it is really the treatment of choice, the TOC for these, and especially for the certain ASDs, is non-surgical device placement. In other words, these children go in for a cardiac catheterization with a interventional cardiologist, and they actually put the patch in place with the cardiac cath. It's really interesting to see those, and those are pretty successful. If for some reason it's so large that they can't do it through a cardiac cath, they'll have to do surgical repair. The surgical repair is usually done through a thoracotomy type opening, and can basically be done very simply and easily on these children. Again, it's one of those problems that you have to see how big the defect is before you can start the treatment on them. Complications that go along with the ASD repair, you can get atrial dysrhythmias or heart blocks, and that's typically related to edema at the surgical site, which may interrupt the conduction system, so we need to watch that. It's usually temporary in process. Of course, the normal type problems that you see with any type of surgery, risk for infection, risk for skin integrity type problems, all of those can be a big issue. Of course, anytime you open up the chest, look at those type of issues. You've got those problems that go along with it. If we do it through cardiac cath, you have to go through all the follow-up care that you do with any type of cardiac cath. Typically, these children who have a repair have a normal life, no big deals. They progress along with just like the other children. If for some reason, like in a third world country, this is not repaired, these children will develop pulmonary hypertension and die a little earlier in life. Just kind of a summary, ASDs are a congenital heart defect that basically is a defect with increased pulmonary blood flow, a left or right shunt, and it's an acyanotic defect, can be easily missed. From that, diagnosis is typically made from a murmur, and then from that murmur, these children are sent for a echocardiogram and maybe for a catheterization. Treatment, again, only if the child is symptomatic or shows signs of congestive heart failure. and typically they'll put them on a diuretic beforehand. Generally, the surgical repair is performed in the preschool age period because of the possibility of spontaneous closure in the first 2 years of life, and the child is usually asymptomatic. Traditional surgery is performed via a median sternotomy, a vertical incision along the sternum for the closure of an isolated ASD. Limited lower sternotomy may be the choice for a minimally invasive type process. Can also be done through a cardiac catheterization. Those things, it just depends on how large the area is and how big of a patch it needs to be done. Most of these children do very, very well after these type of procedures and live a normal, healthy life after the treatment for these devices. Thank you. That's all I have on ASDs.